In this section, we will talk about the macrolide antibiotics. They act via binding to the 50S ribosome and prevent protein synthesis. Generally considered bacteriostatic, but they can be cidal at high dose. Agents available are erythromycin, which is the earliest one, and the semisynthetic derivatives clarithromycin and azithromycin. If you look at the spectrum, erythromycin is generally reserved for gram-positive bacteria, and in fact it can have better activity against them compared to the others. Azithromycin has additional gram-negative cover, and clarithromycin has activity against H. pylori. The semisynthetic derivatives azithromycin and clarithromycin, they are better tolerated, they have better pharmacokinetics allowing once or twice daily dosing, and also has additional spectrum of action. One special use about the macrolides is as motility agents. Generally it's erythromycin because of its activity on the motilin receptors in the gut. The macrolides also have anti-inflammatory properties, and the agent which has been exploited most is azithromycin. Azithromycin is generally considered to be of minimal activity against the Enterobacteriaceae. So the enteric gram-negative bacilli, they are generally resistant to azithromycin, but it has activity against Salmonella, Shigella, and Campylobacter jejuni. All of the macrolides have activity against the atypicals, and that is where they become agents to use in community-acquired pneumonia. If you look at the clinical applications where we use macrolides, it's ear, nose, throat, and lung infections, mainly for their cover of streptococcus and of the atypicals, and also Haemophilus influenzae. In the STDs, it has activity against gonorrhea and chlamydia, and generally part of an empirical therapy for STDs. Azithromycin here can be used as a single 1 gram dose. Scrub typhus, Salmonella, Shigella, atypical mycobacteria, pertussis, diphtheria, all of these are responsive to macrolides. Mycoplasma and chlamydia, the atypicals, are also responsive to macrolides, and Legionella is also responsive to macrolides. Now, when we use the macrolides in atypical pneumonia, generally they are part of a combination therapy. At least in severe community-acquired pneumonia, they will not be monotherapy, and the idea here is to use them to cover the atypicals. In cystic fibrosis-related bronchiectasis or bronchiectasis unrelated to cystic fibrosis, azithromycin has been used as an anti-inflammatory agent, usually given for a long term like 6 months, and the main idea is to decrease the exacerbations. This also has been tried in COPD with frequent exacerbation. Here the dosing is something like 250 milligrams thrice weekly, or maybe 500 milligram once weekly, given for an extended period of time. Over time, we have seen resistance among the streptococcus pneumoniae to the macrolides, and that is why whenever we have a serious streptococcal suspected infection, we generally add another agent to the macrolides to cover the streptococcus well. Staphylococcus also has shown a lot of resistance now, and MRSA is considered almost always resistant to the macrolides. What about the dosing? Azithromycin 500 milligrams day 1, and then either 250 milligrams or 500 milligrams daily for 4 days depending on the severity. But the dose used for typhoid is higher. It's 20 milligrams per kg body weight for children, because that is what it was tried first vis-a-vis ceftriaxone. And for adults, the highest dose is 1 grams per day. It can be used as a monotherapy, or actually it can be used in combination with the cephalosporin. So there is data about the combination therapy of cefixime with azithromycin. For chronic use, the usual dose of azithromycin is 250 milligrams 3 times per week for 6 months or beyond. Adverse events related to the macrolides, they generally GI upset, because they have activity against on the motilin receptors in the GI tract. Hearing impairment has also been noted, and that is mainly related to the long-term use in some of the anti-inflammatory effect conditions where we want to use them. Macrolides can cause QT prolongation, so it should be avoided when patients have predisposition to QT prolongation, or there is another agent which is prone to cause QT prolongation, or in the presence of a QT prolongation already at baseline. It can cause torsades. There are a lot of drug interactions, and they become significant because an agent like azithromycin has a long half-life, a wide tissue penetration and availability, and so the interaction may come into picture even after the discontinuation of the drug. So in the current day scenario, we generally use azithromycin for gram-positive coverage. We can use it for Salmonella, Shigella, for the enteric infections, and anti-inflammatory use of azithromycin is something which has been talked about, so much so that there is now interest in creating an agent with anti-inflammatory effects of azithromycin but without the antibacterial effects, because it has been seen that the long-term use do give rise to macrolide resistant strains.